Yeah, right.
Good evening, everyone. Welcome to iFocus Online, Lecture 138, Glaucoma Session 42. And we are back to our exam special, Long and Short Cases in Glaucoma by Dr. Mayuri Khamar. And I request one of our mentors to please go ahead and introduce ma'am. Harsh sir, over to you.
Welcome, Mayuri, and we are proud to have Mayuri, who is the current treasurer of the Glaucoma Society of India. And we are really proud because she's an old friend. And I must tell you, one of the best things is that we have always attended meetings together, and she's a wonderful speaker. And besides that, she's a very, very good surgeon. And that I knew when she operated one of my one-eyed patients with a wonderful valve, which I saw later. So that is the true introduction. Now for the other introduction, she is a senior glaucoma consultant, Occura Eye Care and Research Center, Ahmedabad, currently. And but she had worked for a long time as an associate professor in the Western Regional Institute of Ophthalmology, BMJ Medical College, Ahmedabad. That is from 86 to 2007, and that is where she must have taken all the exams. And also, please, students, it's very important for you to listen to her. And she has, after that, she also went on to Raghudeep Eye Hospital, where she was a consultant from 2007 to 2018. And she is an ex-honorary associate professor in School of Optometry in Ahmedabad. And she has numerous awards, but some, to name just some of them, she received the Best Research Paper Award in Glaucoma in All India Glaucoma Society Conference in Palampur in 2016, the TV Chandra Award in AIOS in 2013, and R.N. Mathur Oration in Ahmedabad.
It's that even after I reduced the volume, now I've reduced it, but it's okay. I'm thinking it's better that like you talk on the phone and
Please, Prithvi, go on mute.
it's all getting very mixed up on the screen. So we talk on the
Prithvi,
phone.
please mute your
I'll switch off the
microphone.
video now and we'll
Christy,
work on the screen.
tell this Prithvi that to mute his
Yes, sir.
microphone.
Yes, sir. I'll just tell her, sir.
Okay, and she has presented and published lots of research papers in national and international journals. And she has been a part of almost a whole lot of meetings that we always have at the national and so many in the international level. So over to you, Mayuri, and please, our students are really lucky. Please listen carefully to what she has, what pearls of wisdom she is going to give you. Please go ahead, Mayuri.
Thank you, Harsh and Pradeep, for giving me this opportunity, and Santosh too, and team of the Center for Sight. I'm going to share my experience. Is it my slides visible?
Yeah.
Yes, ma'am.
Yes.
Yes, ma'am.
Very much. Yes.
Yes. So today I am given this responsibility of sharing the pearls for how to prepare for long cases and short cases with the perspective to the exam special. And I have designed my talk into a practical approach, what you should do and what you should not. So do keep in mind that these talk and the cases I have taken, they are just and sample. Now we know that the scope of ophthalmology is vast, and it's a 3 years effort that you have put in during your course of residency that makes you comfortable to face the examination. Because now you are experienced and you have seen it a lot, you have read it, but practical that you have done is going to make you comfortable in the exam. Don't be scared of facing the examiner. It is important to have a thorough knowledge of a frequently asked question. See, I'm writing this frequently asked questions, like basics, rather than knowing the rare and obscure facts that will be coming in the later part of your examination. So it is all back to the basic that is must essential to know to pass. Examiner starts questioning with the basic level of questions. Once you clear that level, only then does the examiner pose relatively tough, rare, or newer investigation, something like that questions. So first level is must for you to clear to pass the exam. Now the pattern, most of the center have usually 2 entry segment cases, 2 posterior segment cases, 1 refraction may or may not be there. This is a DNB guideline, but MS can have the similar pattern. And the table viva for the instruments, drugs, and the example, and OSCE is no more there now with the DNB, that is what I heard. So when you do your examination of any case, for example, long case, you are given 30 to 40 minutes. The time varies with the different centers, but mostly it is 40 minutes are given to you. And I've seen that the expert will give you a day before all the students, they go to the ward, they see the cases and the detail is been given. So remember that this is not the correct way of doing. You may go see the cases, but don't rely on the finding of the expert. So examination and writing of your case, the sheet is given to you. So do it and finish it before 10 minutes. Recapitulate everything in your mind before you present yourself to the examiner. That 10 minutes will give you a calm, and you will be knowing what to speak and when to speak. Okay. Now, during this last 2 years, COVID era, the online case for DNB exam, one case was given as a from the center and one was presented online. Even the examiner may bring his own case or photos from the laptop. One of my co-examiner in one exam, he brought his own cases. He was from the local other medical college. And nowadays the examiners are having their laptop and they do post the pictures or photo of the, so be prepared with that also. Now, practice does not make perfect, but only perfect practice make you perfect. This is, I love this sentence. So make a habit to practice case presentation from the beginning. Don't say that I am still first year resident. No, even I started when I was only, I have completed 2 months of my residency. So start with a small case or something. Make a habit of presenting yourself in front of your seniors or your teacher. This will improve your fluency and confidence, but will always help you with the systemic approach to any case that you are going to present or see in your future practical life. So there should be a flow chart in your mind each time you approach a case. This is very important because in theory, what happens? One question is asked and you know what to write and nobody is going to influence in between. You will just make a flow chart and you make a points and you write down. Here, the examiner will start with one question. You may not, you start with the glaucoma case, but the end of the case presentation may not be a glaucoma. It will be something different. So be prepared with the unexpected. Now, these are the list of the glaucoma long cases that can be there in your exam, POAG or angle closure glaucoma, advanced case of glaucoma, neovascular, pseudoexfoliation, pigmentary glaucoma, or sometimes the good cases are not there and the post-trabeculectomy patient is there with some complication that can also be put as a short case in the exam, and the secondary glaucomas. So what should be the flow of your preparation? First, look at the patient data. As we do in our OPD cases, the similar pattern you have to follow when you write down your long case history. Ask patients the chief complaints, relevant complaints, and origin, duration, and progression of that complaints, and any other complaints. Then past history, any similar complaint or other complaint. Then systemic history, family history of glaucoma. Vision should be given, aided, unaided, and the best corrected vision. Detailed torchlight examination that you have to describe. And then slit lamp examination with 90D or 78D or whatever you have. Always go in the exam with these gadgets that you have to have your own gonio lens, 90D lens, torch, ruler, This is the list you must be knowing, so I should not be going in the detail. The intraocular pressure, preferably to be taken with the applanation tonometry. Gonioscopy is always must in all glaucoma cases. And then you can ask your expert to provide the investigation if you wish to have perimetry, OCT or UBM or whatever they have, and the treatment given to the patient. So this should be the flow of preparing a long case. The short case, usually the history is not that more important, but you may ask for the relevant short history of the patient. And basically it is for some finding or the sign that is there in the patient. And on base of that, examiner will discuss the case. It may be one investigative finding, for example, disc hemorrhage, or the visual field showing you some defect or scotoma. Or it could be a case of drug allergy, follicular conjunctivitis. So this is how it can go. And the table viva, I will not go into the detail, but it has an instrument for glaucoma purpose. The gonioscope can be there, trabeculotome, Harm's trabeculotome can be there, tonometers can be there, Shoyos tonometer or the applanation tonometer, Perkins, and various lenses can be there. And UVM pictures usually they put, and then perimetry and OCT printouts, PS OCT. Here in our Ahmedabad center, the glaucoma valve was once kept, and anti-glaucoma drugs, the bottles are kept there. Then mitomycin C, 5-FU, and fluorescent strips. I may be missing some point, but just look at what your center usually is giving for the exams. Now let us start with the grand rounds. Should I ask question to the people who is on the hot seat?
Yes, please.
Okay. So let us start with the first case, how I should prepare. First, age of the patient, 56-year-old female, complaining of notice diminution of vision in left eye for distant as well as near since 7 months. She had come to us for the glaucoma second opinion. Now, the question itself can start from here. Just like any other case of ophthalmology, you have to describe the type of vision loss. Is it a sudden onset? Is it painful or no pain? What is the severity of loss of vision? Any associated symptoms like vomiting or red eye or whatever, that has to be mentioned, and the acute onset. So anybody can answer what are the causes of sudden painful loss of vision, significant loss of vision. Anyone on the hot seat?
Dr. Praveen, are you there?
Yes, ma'am.
Can you answer me this question?
Yes.
Acute onset, painful, significant loss of vision.
Christy, how many hot seaters are there right now?
Sir, we have only Dr. Praveen today. Yeah. Dr. Praveen, can you take the question?
Yes, ma'am.
What is there in glaucoma? This can be there in glaucoma patient.
Ma'am, angle recession glaucoma?
Angle closure glaucoma, acute attack.
No.
Angle recession usually is first there is a trauma, that is different part. But the
Yes.
angle recession glaucoma which manifests later usually have no symptoms. It's a gradual loss of vision. So this is how the examiner can catch you. Okay. So prepared with this history. Now she was diagnosed to have glaucoma in both eyes since 6 months, and on the treatment for both eyes, brinzolamide eye drops and bimetoprost eye drop at bedtime, and brinzolamide 2 times a day. The retinal laser was done for both eyes for peripheral retinal degeneration only 25 days back. Now, patient also had positive family history of glaucoma in grandmother. So this is where they can ask you, what is the importance of family history? So that you should, why it is common or inherited in the, so genetic questions can be asked here, and why you want to know anybody in the family. So what is the importance? You can know what is the type of glaucoma the family member had, how bad it was. Like grandmother was one eye blind, so you can be more vigilant and aggressive in the treatment of the patient. Okay. Pratik, can I just go on because only one person is present and he
Yeah, I think there is only one hot sitter.
and
So
he will
let it
spend,
be the monologue. If you want.
the time is less and I can't just, okay.
Yes, ma'am.
Okay, thank you. So systemic history, no systemic history associated. So what are the systemic history one should ask? Diabetic, hypertension, thyroid dysfunction, hypercholesterol, or asthma and tuberculosis. So examiner will ask you, what is the importance of knowing diabetes? So how diabetes and glaucoma is correlated? That can be, you can answer that diabetic and glaucoma can be together. Diabetes itself can cause the neovascular glaucoma. Similarly, the venous occlusion can be there with high blood pressure, and that also can lead to the neovascular glaucoma. Now, for asthma, we know that the COPD patient should not be given beta blocker, or they can be on the steroid use inhalers. So that can be the cause for the glaucoma. So many things for every systemic disease that you mention, you should be knowing why you are asking this to the patient. For diabetic patient, and you are planning to operate, so you would like to control the diabetic also, and the associated treatment of diabetic retinopathy and all that. Now, they're coming back to the patient, the both eye examination, visual acuity was 6669 with the mild hypermetropic correction with the cylindrical myopic in the right eye and left eye. So with the lattice degeneration, we were expecting in the beginning it could be a myopia, but it is not so. It was a normal refractive error with the add of plus 2.5. Now comes the torchlight examination. Never forget to mention torchlight examination, because sometimes patient had a squinting, one eye is having poor vision and there is a deviation. So, or what is the abnormality that you see with the torchlight has to be mentioned here. Now, this is the right eye of the patient. Always describe in detail the clinical findings, starting from the lid margin, conjunctiva, and cornea, the chamber depth, the iris pattern, pupil size, pupillary, everything that you know, I'm just repeating. But if you see any abnormality, for example, there's a small haze here in the cornea, nebular opacity. One of the student in examination, he thought maybe I should not talk about the corneal opacity, otherwise my viva will go on the cornea side. And the examiner, she just saw it and the whole viva, and she was shouting at him. So never hide any finding that you have seen. It may not be significant, but just mention it. And the right eye was nearly absolutely normal. Mild gray reflex is there, which is age related. Now this is the left eye. You see the size of the pupil. Pradeep, would you like to describe the finding?
Ma'am, the pupil is oval in shape, not complete round.
What the arrow suggests? Okay, I will finish. You can see the smoothing of the sphincter here as well as here. There is a loss of the rough of the pupillary border, and you see small tear kind of thing here. And on the slit examination with the refract illumination also, you can see the white and brown dusting on the endothelial surface in the lower half. So now what we have, past history, we ask her, though she has never given us a history of trauma, because there was a small sphincter tear, we asked her and eventually we found out that she had a left eye blunt trauma in her early childhood. However, it was with the lid swelling which persisted for 2 days. There was no history of loss of vision after the trauma. So, but we could elicit why there was a tear in that part. The intraocular pressure, right eye was 13 and left eye was 20 millimeter of mercury. This is the CCT finding, central corneal thickness 489 and 481 means it is the thinner. So the question will be asked to you, what is the importance of CCT? What is the normal value for Indian population? Should we use the correction table? I have seen many cases where correction is written, but CCT is not written. No, this is wrong practice. No correction table should be used. CCT, the importance is, already you have studied in, listen to the lectures, that it will tell you the thinner cornea has a higher risk of progression. So, and it underestimates the intraocular pressure. But this is all that should be kept in the mind. Thicker cornea may overestimate, and ocular hypertensive trial, they can ask you at this juncture that suggests that the thinner cornea has a faster progression. Indian population, the thickness is variable, but it is 510 to 520 or 30 micrometer. Now, intraocular pressure means examiner may ask you about the various types of tonometers, which is the gold standard still, what is the principle of Applanation-Goldman Applanation tonometer or the Shear's tonometer, and then how do you perform the Applanation tonometer. The technique has to be correctly described, and then comes the corneal hysteresis, and which is the instrument of choice if you want to bypass this corneal hysteresis. So you have to mention about the Pascal tonometer as well as the ORA. Now the gonioscopy comes the next, and as I said, the gonioscopy should always be performed in all cases of glaucoma. The right eye had a grade 3 open angle with pigmentation only on the nasal side, while the left eye gonioscopy had grade 3. I have shown you the pictures of the gonioscopy, the 360-degree pigmentation, and at places it was a patchy pigmentation. Okay, this is a very typical of the pigmentation, that meshwork is studded with the pigmentation. Now, when you speak about this, the question may be arising, how will you grade the angles? What could be the classification, various classification and all that. In the later part of the lecture, I will show you that. The optic now, right eye. Now, fundus you have to describe starting from the media, the disc size, color of the disc, shape of the disc, and then CD ratio, and what is the neuroretinal ring. The margin is smooth or not, any notch is there, and then peripapillary atrophy or any area of the patches of atrophy, and then blood vessels, background, AV crossing or anything abnormal that you see. And the most important in glaucoma, if you can see the wedge defect or the splinter hemorrhage. So they can ask you what are the various signs of glaucoma. So this is what is the right eye, and this is the left eye, showing you the enlargement of the cup, which was 0.7 to 0.8 CDR with temporal pallor. There is a superior notch in this area, thinning is there, and there is a slope here, and bearing of the blood vessel. So every sign you should know, and you have to describe. They will ask you what is the bearing of the blood vessel. Now, this is what I have shown you. For example, this can come, the only fundus examination can come as a splinter hemorrhage over the disc or the RNFL wedge defect like this. So you have to describe this in detail. So what are the hard signs of the glaucoma disc and what are the soft signs, and the differential diagnosis of various non-glaucomatous discs. So that has to be described. Now, one example I have shown, this is the normal, but for non-glaucomatous disc, this is a neurological loss. You can see the pallor of the neuroretinal rim is not corresponding with the size of the cup. So this pallor should give you the suspicion that this is non-glaucomatous. And then the visual field of the patient, you can see it is with the corresponding defect. And this is the time you have to describe about the visual field. Always start with the database of the patient. How old is the patient? What program you have used here? It is 30 days to threshold has been done. Whether the field is reliable or not, that is see here, and the foveal threshold and with the corresponding pattern here. And then comes your total deviation and pattern deviation here. And what is the examination is showing you that there is a superior defect as well as inferior arcuate scotoma and the nasal defect. And now comes the language of this computer printout, that is the glaucoma hemifield test shows it to be outside normal limit. The visual field index is about 55%. And here you will be asked, what is VFI? What is MD? What is PSD? What is the significance? And the reliability test, how will you know the various artifacts? So always use the grayscale for looking at the gray artifacts like pattern, false positive or false negative will be seen. Then which is the pattern that you see? So you describe that the false positive will give you the white areas, abnormal white areas, and false negative can be a clover leaf defect. So many such things, the artifacts of the visual field can be asked at this point. And this is the right eye visual field, which is almost normal within normal limit. It is a reliable field. Always mention, start from here and then mention whether it is reliable or not. Good foveal threshold. This is the glaucoma hemifield test within normal limit. But what you see at this in the grayscale as well as here could be a age scotoma, or right eye usually is done first. So it could be a learning effect also. Then, so these are the questions that can be asked on the perimetric printout. Definition, description of various, what do you mean by 30-2 or what do you mean by 24-2 program? When should be done 10-2 or the macula size 5? When there is a significantly advanced glaucoma or patient have a very poor vision, you can use those programs. 10-2, nowadays we consider this for the patient who is a glaucoma suspect. There is no field defect on the 24-2, but sometimes 10-2 may pick up the early defect. Now you have to describe the field as I have shown you in this, and any specific type of visual defect you are able to see in that, like central scotoma or central stipple scotoma or artifacts, and differential diagnosis of the tunnel vision can be asked here. So there are 3-4 causes that you have to remember. Never tell to you, this is a good poll I should share. I should not say that tunnel vision is there with the 4 causes. Never mention the number. Just narrate them. If you know the 4 numbers and you narrate only 3, it is wrong thing. So never say that 4 causes are there, okay? Now visual neurological field versus glaucoma test field defect has to be described differently, and one can also ask you what is blue on yellow perimetric. This is the example of non-glaucomatous field neurological defect. They are atypical visual fields. They are mostly seen on the temporal side, and it has a vertical meridian. Respect it vertical. While glaucoma, it is more on a nasal side and it respects the horizontal meridian, and the nasal step is very common in that. And this is another non-glaucomatous. You can have altitudinal defect, but centrocecal scotoma. So this was a ischemic AION and very, very typical of non-glaucomatous field loss. Now, what are we dealing with the case that I am talking about? We have now left eye unilateral, could be post-traumatic pigmentary glaucoma. So what to do next? Examiner will ask you, how will you proceed further? Is this right eye normal eye, or right eye is a pre-perimetric state? Is there any role of prophylactic treatment for right eye? What should be the next step in the management? Then one can ask for the further investigation of the right eye. So next investigation could be imaging, because this is the objective test. And again, when you come up with the PSOCT, you have to describe the OCT. Start with upper part, which is a database, and then right eye first. This is the thickness map, deviation map, which is age match comparison. Refractive error is also calculated, and this is the table which gives you various database. Here you have a B-scan charts horizontal and vertical tomograms and the continuous RNFL circular tomograms taken from this part. And then neuroretinal rim thickness compared with the age-matched normal. This is RNFL thickness comparison of both eyes. Here also a T-SNP map, and then sectorial analysis. And this is regarding the left eye, which is showing you a change from the normal. Okay. Now, why, the another question will ask, why there is a gray color in this box? So you should know that when the size of the disc is not matching with the normal database, the color will be shown in a gray color. Okay. So one has to describe what is there in this, and I will not go into the detail. This lectures has been taken. And the next examination could be ASOCT or imaging, which will guide you. See here what is there, the right eye, the normal bowing of the iris is same. There is no posterior depression. There is an opening here. Angle recess is nicely seen. But if you look at the left eye, there is a backward bowing, which could be a sign of the pigmentary glaucoma. Angle recession is not seen. It is a normal here, open angles. So this could be a pigmentary glaucoma by looking at this. So now what should be the next step for the right eye? That's the next question. So washout for the right eye. That should be the answer. How many, now question will be how many days for a various drug washout? For example, patient is using PG analog as well as brinzolamide. So how many days you will have a washout for both these drugs? What should be the washout for timolol or pilocarpine or brimonidine? So these are the questions can be asked to you. And then you will monitor the intraocular pressure and it is good to observe the fluctuation by doing the diurnal variation test. So the question, what is the diurnal variation? The concept, its significance, when it is indicated. It should be done for every suspect as well as post-even treatment. How will you do it? What should be the normal fluctuation in normal individual and what can be there with the glaucoma patient? Now we have done the DVT of this patient and it is falling within the normal range. So the next question is it sufficient DVT? Because it is done between 8 AM to 6:30 PM. So answer should be no. This is office DVT is not sufficient because many of the patients have a high spike in the night time between 2 to 4 PM, about 60 to 70%. So you have to be prepared now that this could be a nocturnal hypertension also. So examiner can ask you on that also. Now this brings the another question. How can you measure the nighttime pressure? So what is the new thing that has come up? That is Sensi-made contact lens, which may do that. It's not available commercially and still not perfect. And another concept is home tonometry, which is also going to be a next future. So this is when you are good in all this, the question can go to the advances. So we did no treatment for the right eye. Observation has been done for this patient. And the left eye, we step up the treatment. 3-drug regime was given. And the target of intraocular pressure, which was set about 15 millimeter of mercury or less, was achieved with this patient. This will again bring to the question, what is the target intraocular pressure? And the whole Viva can finish with the target intraocular pressure. What is the concept? How will you decide? Which are the factors which determine the target intraocular pressure? And suppose this patient, you could not achieve the target pressure in the left eye, or patient developed the drug intolerance with the 3 drugs or 4 drugs. What will you do? Is the surgery option? Which surgery you will choose? Now you say that I will use the trabeculectomy, which is augmented with the mitomycin. So the question will be asked about the trabeculectomy. What are the indications? You have to describe the trabeculectomy. What are the complications, immediate post-op and late post-op complication and management? But mitomycin C is been asked even as a table viva and in the examination. The indication, contraindication, and what should be the concentration and duration of the mitomycin C, and the complications related to the mitomycin use. And the other options, if you don't want to use mitomycin C, so which are the other options? Can be Ologen, can be anti-VEGF, or whatever you want to say. And whenever you say anything like that, you should be knowing that the question can be asked to you. So don't utter a word on which you are not good at. Otherwise, you are leading examiner into the wrong area. Or Ahmed glaucoma wall when it should be indicated. So let us recap what we have. This 56-year female patient diagnosed to have both eye glaucoma with 2 drugs, and then we did investigation and we considered right eye to be normal and off the treatment, and left eye unilateral post-traumatic pigmentary glaucoma in advanced stage. Now, if you have finished this, as you say it is a unilateral glaucoma, the immediate question will be differentiate unilateral glaucoma from bilateral glaucoma. You have to have an excellent history and look for the signs which are common with the secondary glaucoma, because unilateral glaucoma is very commonly seen with the secondary glaucoma. And examiner will ask you to narrate the common causes for unilateral glaucoma. As I said, secondary glaucoma are common. The traumatic angle recession and hyphema, or steroid-induced glaucoma, pigmentary glaucoma. These are the common causes that can be there. Another question can be asked, what are the unilateral secondary open angle glaucomas? So this is the list. Always speak first 4 causes which are very common. The rare causes should not be mentioned first. Always take up the common causes first. And the next question is unilateral angle closure glaucoma. For example, lens-related glaucoma or NVG, CRVO, iris bombi due to inflammation post-cataract surgery, something like that. And another thing is unilateral pass and in between open angle glaucoma. So these are those list of the cases. So my pearl here is always look at the subtle signs, and good history taking is must. We'll share few photographs of the signs. Like this is black ball sign post hyphema patient. You can see the angle recession here on the conioscopy and small sphincter tear in this. Pseudo exfoliation, right to see the dandruff white material on the pupillary area. Dilated pupil will show you this, the various zones of the exfoliation, and when you describe all this thing, dilatation and all that, then they can go to the exfoliation glaucoma. They can ask gonioscopy, how it is different than pigmentary glaucoma. It is a patchy pigment. It may have a symphylosis line and the dandruff kind of material. Then sometimes you can have a eye syndrome kind of patient, angle recession, where you have to look at the abnormal iris pattern here, atrophy, correctopia. This is a Chandler syndrome. Here it is a Cogan-Rees. You have to describe this pattern of the nevus. Or simple Krukenberg spindles that will arouse the suspicion of the pigmentary glaucoma, and you can see the pigment dispersion with the symphylosis line here. Or glaucoma pattern like this is suggestive of previous acute attack and a shallow chamber. You have to do gonioscopy in such patient. Another sign of the previous attack could be the smoothing of the sphincter like this, or the atrophy of the sphincter. Now this is a case, young male with a recurrent unilateral glaucoma. You see the pattern of the iris is different, metal bitten appearance. This is how the suspicion should be there. It is acute heterochromic iridocyclitis. Now I started taking photo of that because it was only patchy, a bizarre pattern on the nasal side. But while doing the gonioscopic photography, you can see the pink color has come up. So this is the sign, Amsler sign, that has started. And it is very commonly seen with the inflammatory glaucoma with the micro vessels in the angle area. So it is the unilateral glaucoma, which has a typical iris pattern. APs could be there, and heterochromia. Or silicon oil glaucoma, you can see the small bubbles that has to be described, or neovascular glaucoma, the ectophian uvei, blood vessels, and the new vessels may or may not be seen with the fibrovascular synechia. Never forget to lift when patient had unilateral glaucoma and had a steroid depot like this. These are the intractable glaucoma. So describe all your findings into detail, like KPs with the Poisson glaucoma syndrome or some tumor in that. You can ask for the other investigations like UBM or the iris bump. You can see the iris cyst here. The pseudo exfoliation patient UBM, how it is going to be helpful. It will tell you where the optic and haptics are, whether they are rubbing with the ciliary body. If time permits, this is the second case. 55-year male patient who had a diminution of vision since 6 months and occasional pain. Since 2 months, he has noticed dull aching, heaviness in the eye, headache. This is tolerable and self-limiting. Temporary decrease in the vision or blurring in the vision and no specific diurnal variation. Or now the history part, it is must that you mention what is no. So your examiner know that how you are progressing in your examination. You are excluding other causes like no history of trauma, color halos, no topical or systemic medication, which may have led to the angle closure, no. So all these no findings are to be mentioned. And then you do the torchlight examination. Here they can ask you what is the oblique flashlight test. How will you know that it is a shallow chamber? So when you put a torch on the temporal canthus or temporal side, and you can see the iris pattern on the opposite side, it is a deep chamber. But if it is partly seen or not seen on the opposite side, nasal side, it is the very shallow chamber and it has a high sensitivity and specificity. Now this is how you describe right eye and left eye of that patient. And the congestion, the question can be asked to differentiate the various ciliary congestion and conjunctival congestion. And the pupil is also to be described, particularly when you have angle closure, the pupil is semi-dilated, vertically oval. So the question will be asked to you, why it is so? Why it is vertically oval? Okay. So, and how will you differentiate it with the iritis? So where there is a myotic pupil, while this is a dilated or semi-dilated pupil. Now this patient had a shallow von Herrick was grade 1. That has to be mentioned. What is the lens changes? That also has to be, because it may help us in deciding the management part. The vision is 636, 624 and the IOP was 36 and 32. As I said, never hide any finding, additional finding that you see in the patient. So this is the right eye and this is the left eye of the patient. And so what should be the next investigation for any shallow chamber? Gonioscopy. So here they will ask you to describe angle finding from anterior to posterior, what you see. And what von Herrick classification, how will you perform it? What should be the thinness of the slit? Where should be kept? And any other test that you would like to do for the angle occludability. So this is the von Herrick and Schaeffer's comparison, how it should be done. And the various gradings, like this is angle 0, nothing is visible, grade 2 to 3, and this is grade 4, you can see even ciliary body recess. Now, then in your sheet, you have to draw goniogram, and 3 things has to be mentioned for each quadrant, which is the posterior structure that you see will decide. Then secondly, what is the contour of the iris, peripheral iris, convex, concave, or straight. And now what? You have done that. So what should be the next finding? In this patient, if you can't see the angle structures, then you have to do manipulative or indentation gonioscopy, and which is the posterior structure. With this method, you can see that has to be mentioned. Also mention how much is the amount of pigmentation in the trabecular measure. So manipulative gonioscopy, when would you like to do? If you have 2 mirror or 1 mirror gonio lens, then you can do manipulative gonioscopy. And for indentation gonioscopy, you need 4 mirror. So the person can ask you about the gonioscopes, which are various gonioscope, direct, indirect gonioscopy, where it is indicated. Nowadays, lot of angle surgeries are being done, so you should know about the direct gonioscope also. So how to do manipulative? Ask patient look into the direction of the mirror. Suppose mirror is superior. Ask patient to look up and you tilt lens towards the center. That will bypass the over the hill phenomenon and you can see the angle. While indentation, by pressing with a small base, flat base conio lens, you can push the aqueous into the periphery. So appositional synechia will move away and the synechial closure will remain as it is. So this is an example of showing you the manipulative. You can see a very narrow angle. On manipulation, you can see the detailing and few synechia here. The same person will ask you, what is the parallelopipe or the corneal wedge technique? So cornea, you see where the wedge is ending, it is the Shalby's line. And then where the iris pet line is and what is the change here. See, they both are not meeting in one line. That could be a oppositional closure. And with the indentation, you can see that line is going inside and the iris is here. So these are various techniques of finding out whether it is a true angle closure or oppositional. Now the question comes, how will you differentiate iris process from the peripheral antisynechia or goniosynechia? And we know that the iris are lacy cord-like pattern follows the depth, while pars are broad and pent up and may go up to the Shalby's line. So this is how the exam will go on. The disc sign, as I said, you have to describe this in the detail. And these are various signs. You have to mention the what is the isn't rule. The inferior is thicker than the superior, something like that. They can. So we know all these signs. So take the examiner. You lead the examiner. You speak something which you are good at. Now this is the notch or the configuration of the neuroretinal ring is showing you the notch here, color of the disc or neuroretinal ring, splinter hemorrhage, peripapillary atrophy, beta zone enlargement. All this has to be, even the tilted disc should be seen with the 90-day examination. And then the look at the RNFL wedge defect. And which is the filter one should use, which is the red free, which gives you beautiful view of that. Now this patient had, the one we are talking about, had a PI done in this eye, both eyes, as a management part. So now the question comes in the form of lasers in glaucoma. I am sure Dr. Harsh must have taught you about this. So when will you repeat the gonioscopy after the laser? What will you know by doing that? And the question related to laser PI, be prepared. Many a time this can ask as a theory question as well as in the practical. What is the indication, contraindication? What should be the site and size of the PI, like atrophic area, supranasal, which is covered, could be the good site of the PI. And how will you confirm the patency of PI by looking at the retroillumination? Then gonioplasty, then cyclodestructive procedures of the detail of that, and the recent laser procedures which are there has to be mentioned. Sometimes the Abraham lens is kept in the instrument table. So you have to describe the button that is there on the superior part is 66 diopter plano-convex button, which gives you magnification. So if patient is not controlled, what will you do? The medical management, again, target IOP, how to decide and all that. And what is the role of lens removal? For example, this patient vision could not be improved beyond 624 and 630. So any role of the lens removal that can be discussed at this point, and which is the latest study, which describe the significance of lens removal here. So primary angle closure suspect, for example, this is the confirmed case of angle closure. But now they will ask you what is the latest classification of primary angle closure glaucoma. So in that case, you have to describe primary angle closure suspect, primary angle closure glaucoma, chronic glaucoma, and acute attack. So what is the role of provocative test? When would you like to do it? So dark room provocative test, you should know how you are doing. If you have done in your practice, in your clinic, you are knowing it, then what are the other alternatives? If you don't want to put that, the other alternative could be using the anti-segment imaging in glaucoma. For example, you can see this is the anti-segment imaging. You see there is no light and the iris is touching the outflow facility here. And typical bowing of the iris is thin, pupillary block, and with the lights on, the angle has opened up. So these are the dynamic changes that can establish by doing this imaging technique if you have. So now acute angle closure sometimes can be there, and they will ask you about the sign, symptoms, manifestation, which are the risk factors, and but this could be there as a full question written paper also. And this is how, what should be the treatment they are interested in, how you manage the case which has come in the emergency. So intravenous fluid and the topically, never forget to mention the prednisolone eye drops, because unless you control the inflammation, it's not going to happen. Even the laser PI is not going to be successful if you have not controlled the inflammation. And when acute attack is relieved, what will you do? The laser PI, and later on surgery if required. Last two cases, 62-year male farmer, known case of glaucoma, left eye surgery was done 3 months back on timolol in right eye. No systemic complaint. The only complaint patient had was headache off and on. So if you, we saw the past record 3 years back, he had 618 and 660 vision, both high 0.9 CDR, good blab in left eye, normal CCT and the normal pressure. This is the gonioscopy, and this is the latest finding of that patient, the visual field. If you see the field, what is your obvious here? One should say it is following the vertical line. But what was the previous visual field? This was the field. Left eye he could perform, and it was a quadrantic loss. But this was the progression, one-eyed patient. So what to do? That is the next question. This can see the both the fields can be kept for you as a short case, as a sign. So what should be done? Carotid Doppler done, DVT done, compliance reconfirmed. So what should be the next? We did the visual PSOCT to reconfirm that he is doing correctly. Now you see the PSOCT, the ganglion cell analysis, is showing the change on the opposite side rather than this side. And see the bizarre pattern here. It should have been here for the glaucoma. Good thickness match. So what should be the done? And patient complain that the whatever doctor you are doing, my headache is not going now. It is becoming more and more severe, and some weakness on the left side. We did the MRI, which should have been done long back. It was a pituitary macroadenoma. So take home message is normal tension glaucoma diagnosis to be made after exclusion of all other conditions. Every persisting new complaint of the patient should be given due attention. An MRI and neuroimaging is must. Always keep high level of suspicion when the findings are not typical. Thorough history examination. Check the color vision to differentiate it from glaucoma. And neuroimaging is must. Okay. If time permits, then I will go further. Otherwise, I stop here. Should I?
Yeah, we have time.
Okay. For 46-year female, complaining of itchiness, redness in both eyes since 2 months. Diagnosed to have glaucoma since 6 months. On brimonidine timolol combination 2 times a day since 6 months. Family history of glaucoma in mother and visual acuity was 6.6. I will go fast now. Each point I will not stress. Only the few pearls, how you should, like in your private practice also, this will help you. So intersegment examination, this is the right examination. Pradeep, would you like to describe your finding here? No.
Is Praveen?
Praveen.
Yes.
Yes, ma'am.
Can you describe the finding? Okay, I will do it now because time is running fast. You see the normal cornea, the chamber appears to be shallow. What is there in the conjunctiva? Few follicles you can see, and the ocular surface is not healthy. Even the lid margin is not healthy. And Von Herrick is also confirming the shallowness of the chamber. This is other eye view. what you see is the follicular conjunctivitis, very, very typical, severe follicular, very typical of brimonidine toxicity. Patient is on brimonidine, the intraocular pressure 22, and the pachymetry was on thinner side. Now, at this point, they can ask you what are the various drug toxicities that you see with the anti-glaucoma medication. First is ocular surface disorder, mebobinitis. With PG analog, what are the side effects? Elongation of the lashes, pigmentation, periocular pigmentation. As soon as patient enters the clinic, you can know that this patient is on that. Then the pigmentation of iris, if it is blue, a light color iris. Then filamentary keratitis sometimes is so common with the timolol, dryness of the eye. And then eczema, common with the brimonidine. Even PG analog can have this kind of effect. Eczema, periocular. So these are some of the drug toxicity, and one single case can be there as a short case. So gonioscopy of our patient was done and showed the narrow angle, but which opens up to grade 3 on indentation. The anterior chamber depth was 2.27, and this is the disc examination, and the corresponding, though there was a inferior thinning, nothing was there on the perimetry examination. So it is a primary angle closure, ocular surface disease due to drug toxicity. So stop the all anti-glaucoma treatment at present and started on low dose lotenepredol with the lubricating eye drops. After 15 days, everything clears up. Okay. So intraocular pressure went up to 30. So we started patient on travoprost or any PG analog is good enough. And after 5 days, the pressure was normal and the RPI was planned. 82-year male retired on routine checkup, both eye vision, 6966. Operated for both eye cataracts 10 years back, no family history of glaucoma, very nicely placed pseudophakia. The IOP was 22 and 20, pachymetry was normal, open angles. This is the disc. Now describe the disc finding here. Tilted disc, large cup, nasalization, laminar dot signs, pallor, Tisnit rule is broken, and very in details you have to describe the findings, and these are the corresponding field defects. Okay, and the GDX was there at that patient. We did and showing you the defect. The diurnal variation was not fluctuating much. So it is though this has a advanced changes, the pressure was not very high. So what are the options for this patient? That can be asked to you. 82-year male who has no other complaint. He is living happily. So should you start medical therapy, surgical, or selective laser trabeculoplasty is another option, which can take care of this. So that will bring you the question of what is the SLT full form, mechanism of action is that. Where will you do it? Describe the technique. The lens used is Latina lens, how it is different than other lens. What are the complications of this and how much is the reduction? How long it will last, the action of this? These are the small things, but can be asked to you if the selection is done for that. And this is the last slide. Just to show you, even the short case can be there in the ward where suppose TRAB MMC blab is shown to you. You have to describe. How will you describe this blab? So describe what is the clock over extent, how much is the elevation, what is the vascularity of the blab, any other thing like here express TFD is done. So that is seen here. Here the ologen is implanted. So how the ologen blebs are different than mitomycin bleb. So many questions can be asked. And surgically, what are the problems of this surgery, filtering surgery? So many questions can be asked by just having this kind of case in your exam. So last slide, the pearl is always lead your examiner by saying something in your question answer. So he can take up that point and ask you question on the things that you know of. Never lose eye-to-eye contact. I have seen people just looking down. Why you should do that? If you are confident, look into the eye of examiner and try to convince him with your answer. Never be shy of saying, I don't know. Because if you don't know and just start giving wrong answer or bluffing, he is going to enjoy it. The examiner will lead you on a wrong path and all Viva will be finished with all the wrong things. So if you are sure of your findings, persist on that. Because the expert has given you finding day before, the night before. But sometimes examiner may have changed it, or he is an expert, may not be as good as you. So always find out your findings and persist on that. And the expression of examiner may be elusive. Sometimes they say, oh, are you sure? Don't change your answer. If you are sure, continue with that. So friends, I hope I have done my job. I value your patience and kind attention. Thank you and all the best.
Thank you so much, ma'am.
Wonderful.
I do.
Wonderful. You know, very experienced teacher was there. And,
We also learned.
No, you can.
yes. And you took us to many, many things. And unfortunately, you know, the students were not there. Too many hot seekers. Otherwise, you know,
No, but
the two-way communication.
They will always look back. You know, they will look on the YouTube and this is a popular lecture. They will always look. So it doesn't matter.
Because I
very
had
useful,
so many cases to share with one single pearl, and it will change your management pattern.
But you know, one good
it
thing
was
is there.
examination special. I just restricted myself to that.
Because of the monologue, you were able to take so many cases. Otherwise, you would not have taken so many cases. So anyway, the students will log in and they will see on the YouTube and they will learn a lot. They will learn more now.
Thank you.
Wonderful. So you were a tough examiner.
I have been examiner, but very good examiner.
So
I always give them a clue to the answer, some lead. So if they are going away and I am there as their chief examiner, even the other examiner is trying to pull, I will try to keep my students safe by giving.
Mayuri, if the person is not confident, where should he look? If he is confident,
no, but he will be confident if he starts presenting himself from the first year. At least they should have presented 10 to 15 cases before they appear for the exam.
Yes.
Make a habit of presenting. That will remove the fear from you, and you will have a tendency to see at the sign. See, practical examination, that's why it's very important. Whatever you have seen in your practice during that 3 years will lead you through the exam. This is not theory. Theory, everyone can mug up and write up. And nobody is there to disturb you during the examination. Here, practical, if one question is not answered correctly, you are going to the other part. It may not be glaucoma, it could be cornea, it could be lens even. So one should have a practice that will, and always use your seniors' goodwill, ask them to listen to you when you present, and your teacher will always help you how to present yourself.
I am surprised that the teachers are bringing the cases on the laptop, not the physical cases.
I know. We learn with the physical only.
Whatever they can do now, what we can do.
But you can think of, Pradeep, you guys can, I have multiple cases, similar you might be having. So we can have multiple such cases for them and they can learn.
Thank you very much, Mayuri. I think that was wonderfully done. And Pradeep,
yes, very good.
Yeah, so Mayuri can go and have her dinner.
Yes, thank you. Okay.
Thank you.
All the best, all of you.
Thank you, ma'am.
Bye. Good night.
Night,
Thank you,
sir.
ma'am. Good night.
Bye.
Praveen, you did